So now coming to the cardiac output and its regulation. What is cardiac output? Cardiac output is the volume of blood which is pumped from each ventricle in 1 minute. So basically one ventricle, how much blood it is pumping. It is there in the series. Don't think right ventricle is pumping this volume and left ventricle is pumping the other volume. It is the same volume which is circulating in the blood. So the cardiac output is nothing but the stroke volume into heart rate. For one beat, how much is the output? That is stroke volume and multiplied by the heart rate. So 90 is the stroke volume, which we saw it before also. Then 72 is the normal heartbeat, so it comes around 5.5 liters. So if we understand the factors regulating stroke volume and factors regulating heart rate, then that is the regulation of cardiac output. So coming to the regulation of stroke volume, it is the most important one. Stroke volume is under the influence of three things. First one is called as preload. Whatever load the heart is getting, that is the preload. So first one is preload. Next thing is the intrinsic contractility of the heart itself. So first one we are done with preload. Next thing is the contractility of the heart itself. Heart's pumping capability itself is called as contractility. Then the third thing is called as afterload. Third thing is called as afterload. It is the load which acts after the ventricle starts to contract. Preload is before the contraction, whatever load we put it, then that is preload. Afterload is the ventricle has started to contract, but suddenly it is facing some obstruction. That is the afterload. So now let's try to understand each one of them. What is the determinant of preload? What is preload? Whatever venous return is coming to the heart, that is the preload. So it is determined by venous return. It is determined by the venous return. And what is the index? Venous return, we cannot measure it, but whatever venous return is coming, it is forming the end diastolic volume. At the end of diastolic volume, whatever volume is there, that is the preload. So index for measurement is end diastolic volume. It cannot be measured by the venous return, it can be measured easily by the end diastolic volume. So what happens whenever the end diastolic volume is more, what will happen to the preload? The preload will increase. So what will happen to the stretching of the muscles? The stretching of the muscle will increase. If there is stretching of the muscle is increasing, what will happen to the force of contraction? The force of contraction is going to increase. What is this law? This law is called as Frank-Starling law. This law is called as Frank-Starling law. So this is very important. But this Frank-Starling law, we should remember one thing. This stretching should happen within physiological limits. This Frank-Starling law states that the force of contraction is directly proportional to the initial length of the muscle fiber, but within physiological limits. I cannot stretch it too much and cause an injury and say that it is not contracting properly. It should be within physiological limits. Now coming to the second part, so it is directly proportional. There is an increase in preload, there is an increase in stroke volume. So it is directly proportional. Preload is directly proportional to the stroke volume. Second comes the contractility. It is pretty simple. If the contractility is good, stroke volume is going to increase. So contractility is directly proportional to the stroke volume. Next, coming to the afterload. Afterload is like a resistance. It is like an obstruction. What is happening? So afterload, if it is increased, then obviously my stroke volume will be decreased because it is acting like a resistance. So it is determined by total peripheral resistance. It calculates all the resistance in the arteries and that will determine the afterload. But we cannot measure the peripheral resistance in all the arteries. Instead of that, the index used is mean arterial pressure. If the mean arterial pressure is high, then it means that the heart will find it difficult to pump. So it's pretty simple because heart is pumping against the arteries. If the pressure is more here, pressure is there, what will happen? Heart has to pump it very forcefully. It has to work hard. It will be difficult for the heart to pump. So it is indexed as mean arterial pressure. So the afterload, whenever it is increasing, it is going to decrease my stroke volume. Here the proportionality is inverse. Heart rate, afterload is inversely proportional to that of the stroke volume. This we have to remember. These are all the parameters which is influencing the stroke volume. Now coming to the influence of heart rate, all of us know heart rate is under the influence of autonomic nervous system. This autonomic nervous system has sympathetic supply and parasympathetic supply. What does the sympathetic do? It increases the heart rate. Whereas the parasympathetic, it decreases the heart rate. This everybody knows. So these are the two things that is controlling the heart rate. Then coming to a non-important curve, which is called as Frank-Starling curve. So whatever we have discussed now, that is the Frank-Starling curve. This curve is drawn between the end diastolic volume and the stroke volume. If I draw between the end diastolic volume and stroke volume, what is it? It is Frank-Starling's law. If the end diastolic volume is more, what will happen to the stroke volume? It is going to increase because there is a stretch in the muscle. So here the blue curve is the normal curve. The blue is the normal curve. The rest everything is abnormal. The blue curve is going here, but after some time you can see a decline here. Why? Because this is the physiological limits I was talking about. Whenever you increase the stretch of the muscle up to a certain point, there will be an increase in stroke volume. As you can see here, whenever we are increasing the length of the muscle fiber, the stroke volume is also increasing up to certain point. After that, it is falling. So this is the physiological limit. Now coming to the curve which is above, it means that for the given stroke end diastolic volume, the stroke volume is more. When can it happen? If the heart is contracting forcefully, then obviously it can happen. So what is the example for that? The sympathetic stimulation. Whenever there is a sympathetic stimulation, then the force of contraction can be increased without increasing the end diastolic volume. Then coming to the red curve, it is falling below. When can it happen? So this can happen whenever the parasympathetic drugs are given. So this can happen whenever parasympathetic system is active. Parasympathetic system is active. And it can happen whenever there is hypoxia to the tissues. Otherwise, it can happen in hypercapnia. So basically, anything which is destroying the heart tissue, it can lead to this condition where when there is a fall in the stroke volume. Then coming to the last condition, which is more interesting, here you can see that there is a steady increase up to a certain point. After that, there is a plateau. Whatever end diastolic volume I increase, it is not increasing the stroke volume at all. So what has happened to the heart here? The heart, we can say it has failed. This is an example of heart failure, cardiac failure. This is the cardiac failure graph. So this graph is very, very important. So what happens in cardiac failure and how can we improve the graph to the normal condition? So basically, if we have some mechanisms to bring it close to the normal graph, then that will be helpful for the patient. So what all things that we can do? Let's see this example and you guys are going to tell me what are all the drugs we can give. So in this condition, this is the cardiac failure curve and this is the normal curve. As you can see here, I have pointed out if I give some drug, it is just increasing the curve or increasing the sympathetic activity. It is moving the curve upward. So what is the example for it? It is basically increasing only the force of contraction. Here just the force of contraction has happened because there is no volume reduction. If there is volume reduction, the curve should have moved to the left side somewhere here. It is not moving. In the A curve, I'm just talking about the A here. In the A curve, only the contractility is increased. So what is the drug that can increase the contractility? Example is digoxin. Digoxin can bring the curve to the A. And let's talk about the curve B. In the curve B, what has happened? There is no increase in contractility, but there is a reduction in end diastolic volume. Is it good or bad for the patient? It is good for the patient because this patient up to here only he can increase the cardiac output with respect to end diastolic volume. After that, whatever end diastolic volume is there, that is going completely useless. And if the end diastolic volume is increasing, what will happen for this patient? The cardiac failure will go keep on progressing. So if I reduce the volume, just by reducing the volume, I can preserve the heart for a future. Like the cardiac damage can be prevented. It is not going to heal it, but the cardiac damage, whichever is going to happen, that can be prevented. So what we have to do for eliminating the fluid? We have to give him just diuretics. So diuretics, that's why in cardiac patients, you will always find the diuretic in one of the prescription. They will always have one diuretic component to reduce the fluid overload in the body. So that is the drug which is B. Now coming to C. C is looking beautiful because see here, it is increasing the like contractility also. At the same time, it is reducing the volume also. It is doing both things. Which drug can do this? There is one drug called as ACE inhibitors. ACE inhibitors. This ACE inhibitors, what they do is basically their angiotensin 1 is going to get converted to angiotensin 2. And the enzyme responsible for this is ACE. So we are trying to block this. We are trying to decrease the production of angiotensin 2. Why? Because angiotensin 2 will increase the hypertension, like it will increase the afterload. If hypertension is there, my afterload is increased. So we are trying to do that here. It does two things. It does venodilation also as well as arteriodilation also. So basically ACE inhibitor, what it is doing? It is doing the venodilation, dilation of the veins, and arteriodilation, dilation of the arteries. Both it is doing. How does it help? Whenever we do a venodilation, what is going to happen? There is a decrease in venous return. There is a decrease in preload. It is going to decrease the preload, because I don't want preload in this patient, but for others it is helpful. For in this patient, it is completely useless. Then arterial dilation, what it is going to do? It is going to decrease the total peripheral resistance. If total peripheral resistance is decreased, it is going to decrease the afterload. And decreasing the afterload is a very good treatment, because if my heart is pumping against resistance, it will be very, very difficult for the heart. So this ACE inhibitors can do both, can decrease the fluid also, as well as it can increase the contractility also. So both can be done. So this is the cardiac failure curve along with the normal Frank-Starling's law curve.